Well, welcome everyone, and thank you so much for joining the session. I'm Corinne, and I have the honor of serving as president in the Oxford Alumni Association in Mexico. As you might know already, this is the second session in our Three Capitals lecture series, which is a collaboration between our chapters in Washington, D.C., in Ottawa, and in Mexico. And I'm joined here by Sean, who's the president of the Washington, D.C. chapter, and David Sachs, who's the president of the Ottawa chapter. Akash from Ottawa, Katie from DC, and Paulina from Mexico have also been absolutely critical to making this lecture series happen. Sean, David, any words from you as we begin the webinar?
I just want to say thank you and good morning to our Oxonians to the north and south. And thank you, Corinne, in Mexico City for organizing today.
Yes, and welcome to everyone logging in from Canada. And as Sean said, many thanks to Karine and the Mexico City chapter for for hosting what promises to be an exciting and elucidating talk.
Thank you, David. Thanks, Sean. And just a quick word on this lecture series. I think in many ways we've been finding that this is an opportunity for us to find unity and strength and resilience despite the challenging circumstances around us. And through this lecture series, I think we've all been finding Oxford chapter leaders who are willing to collaborate and a community that really wants to be engaged, and speakers who are so generously willing to share. And our speaker for today is Dr. Moritz Kraemer. Dr. Kraemer is a research fellow in the Department of Zoology at the University of Oxford and an associate of the Oxford Martin program on Pandemic Genomics. He's joining us directly from Oxford right now. And I wonder what the temperature is like right there. And he's going to share his research on the measures that are required to contain the spread of the coronavirus. His research draws from a global consortium that gathers a very rich database of epidemiological data. And it promises to be a very, very fascinating lecture. So thank you so much, Kraemer. And we'll pass on the word to you.
Right, yeah, thank you. Thank you so much for the introduction. Let me just share my screen so we can get started. So first on the report of the weather, it's been raining for the last kind of 4 hours. We are at about 15 degrees Celsius, so settling into the autumn, and many of you may still have a much nicer temperatures. But thank you very much for the invitation, and thank you very much for the opportunity to speak to many of the alumni across the world, especially in the Americas, where there's lots of activity of coronavirus, of course, still going on, and it's probably a very challenging time for many. So I'll be presenting, so I'm based in the Department of Zoology, as said, and I'm leading a program in Pandemic Genomics from the Oxford Martin School, which you may have heard of while you were all in Oxford at some point in your careers. And I'm excited to speak about some of the research we have been doing since the beginning of this outbreak, since it started. And I've worked on many emerging infectious disease outbreaks in the past, including the Ebola outbreak in West Africa and the DRC, the Zika outbreak in Brazil and Mexico, and the dengue outbreaks there. So this is just another chapter in these emerging infectious diseases that occur. And this one, unfortunately, has turned into a large pandemic across the world. So I want to give you an overview of sort of the initial kind of first few months really of this outbreak, where everyone was trying to find a way to understand what was actually going on and really trying to identify like the basic epidemiological parameters driving this pandemic and what that could have meant for our understanding for how we predicted spread. I'll then jump in to discuss a few of our early works in China, where we try to elucidate on the role of human mobility in the spread of COVID-19 and what that would also mean in terms of how we may have been able to predict, like to actually mitigate some of the effects of that geographic spread, and then go into sort of like more sort of recent work where we are trying to identify what factors actually are locally driving epidemics and whether those are related to urbanization and crowding, and what that ultimately means also for the world in terms of how many people may have been infected by this disease in each of the different localities, from big cities to more rural areas. And then leading on from that, trying to understand, well, now that we have some sort of understanding of the process of spread, what does that actually mean as vaccines may become available? I'm not myself a vaccinologist, so I won't speak about the details of the vaccine and when they may become available. I'll speak more about once they become available and they're safe, how could we best utilize them in terms of effective targeting of certain populations so that it contain and mitigate the spread of this pandemic. So we came together as a consortium early January. I think I just came back from the holiday of the Christmas holiday, and we've heard about, you know, rumors that things are happening in Wuhan, and like really the entire academic community then usually comes together to say, okay, what's going on, and like how can we support this effort to try to understand what's going on. And at the time, you know, we had an informal network of collaborators coming together to try to collate anonymized individual level data on this outbreak. And that grew very, very quickly into a group of 150 people. And we all had to coordinate, of course, you know, through Slack and other channels to then coordinate this data collection effort, which was very much one that grew very, very big and global as a sort of within the first few weeks of this outbreak. And was really, I think, the first time that during such outbreaks, the global community really came together collaboratively and not was isolated in these academic departments, but really there was a drive for collaboration. I think that has persisted throughout this entire outbreak, where there's really, really great collaboration between scientists across the world. We call this now the Global Health Data Science Initiative. This initiative, you can see kind of here, is like a group of scientists and mostly scientists really across the world. So some are, you know, near where you are, around Washington, DC, in Georgetown, Johns Hopkins University. Others are Northeastern, Boston, where I was previous to coming to Oxford. And then we have local working group leaders from Latin America. So Bernardo Gutierrez here is himself from Ecuador, a PhD student here in Oxford, but is leading sort of the coordination of this working group around the Americas. And then we have working groups across all continents, really, to try to have sort of that bridging between a global effort with local expertise. That was a very crucial one in this outbreak. As you know, locally people know much more about what's actually going on and like how data is being collected and so forth. And you all know that there's no shortage of data, and many of you have probably, or like are daily looking at sort of, what is going on around the world, where are cases rising, where are cases falling. And, I'm an epidemiologist, so there are classically three types of data that are relevant when we think about outbreaks. And one are the aggregated case counts. So many of you probably know of the Johns Hopkins dashboard. So these are sort of, daily numbers of cases aggregated to a county level or to a country level to try to understand, how many cases have occurred. Then in hospitals, they're clinical information. So whenever someone is admitted to hospital, of course, there are records of these individuals, but that is highly identifiable information. So this is not information that's usually publicly available. And we opted sort of for that middle bit here, which is like individual case counts, but anonymized. So what that allows us to do, for example, is understand with much more precision on, how people are actually becoming infected. So for example, what is the date of onset of an individual case until they actually go to the hospital, until they get a confirmation date back? And how does that vary across different geographies around the world? So for example, if you think about the United States, in like California versus, let's say, the East Coast, how long does it take until someone who has beginning of symptoms actually then goes to the hospital and then gets a PCR confirmation test back until they actually are certain that they have the disease? And these are types of information that are incredibly valuable, especially early in an epidemic, to understand, the hidden spread of COVID-19. And we all notice at this point, right, that lots of infections actually occur in a state where they're pre-symptomatic. So either people don't have symptoms at that point yet, or they're very mildly symptomatic. I'll go into some of that detail later. The good thing about these data are they're anonymized, so they can be shared, but they come from very disparate sources. So we really need that consortium to bring this type of data together. So just some insights on like what this data actually contains, and this is all openly available, can be downloaded. So again, like one of these efforts that we try to push really forward is like that open data, open sharing of data is incredibly important during those types of outbreaks. What the data also includes is travel history. So initially in the epidemic, especially, it was very important to understand, have people had travel history to China, for example. I know you may remember this, some of you from Seattle, this small outbreak there that people were asking, okay, well, did people have contact to a case in China and when they came back infecting locally individuals? And a lot of discussion at that point really about, how much transmission is human to human and how much initially was from that initial outbreak cluster in Wuhan. And so this was like a crucial data point in the beginning of this outbreak. And really we wanted to do this at a global scale. So just a timeline of like how this all actually developed. So the volunteers came together in early January. So this is really the time when we first heard about this outbreak here in Oxford. And then very quickly we moved to like a state where we really wanted to come together to write sort of our initial assessment or cataloging of this data together, so it could be then used by other researchers immediately as we sort of moved into this outbreak. And by the time we reached April, and it seems like a long time ago, but like until that point we could actually put such individualized data into the database, but now the cases grew so quickly and so large that we got support from Google.org, so this is the philanthropic arm of Google, and some engineers to help us scale really this effort so that we could actually bring in such a huge amount of information. And now with over 25 million cases, of course, that's really, really necessary to build a sustainable infrastructure that prevents also for future outbreaks, have an actual infrastructure in place where this becomes more formalized and isn't something that needs to be done ad hoc. So we're fortunate to got some funding then in April, and also, and this is like pretty amazing, Google provided 12 engineers and product managers to help sort of like bring structure into this entire system of individuals like being involved in this process. And I think at this point we are about 50 people really working on this day to day, and that wouldn't be possible without the help of some very structured work from an engineering perspective. And sort of if you just have a little look at this data, so you can see here kind of the timeline of evolution, just a video kind of like the initial cases popping up in Wuhan and spreading around China and Southeast Asia, but then these huge clusters emerging in Iran, Italy, and then the UK, of course, and the United States a bit later than that. So you can really see the precision of this type of information, and like at a city level, not really at a country level, and the evolution of it. And then the question really became very quickly, how do we actually use this data to predict the next move of the virus, right? And we're still talking about like late January, early February. So this was then a report in Science where there were people coming together from computational modeling and from the data side to understand, well, if we have this information and we have flight networks and human mobility, how do we see the evolution of this virus across the world? And this is, and you can imagine this was only like 3 to 4 weeks into the epidemic when everyone was trying to race towards like making those predictions. Many of them weren't considered by health officials and governments, but some were, especially, and we noticed today in New Zealand, South Korea, and other countries around the world where very early on contact tracing was emphasized, lots of testing was ramped up, and classical epidemiological sort of work was done to contain and mitigate these outbreaks in particular locations. And at this point, we're talking sort of like late March here, the data had been used by, I think, the 2 first modeling studies in Science published between February and March, and then later on to define the incubation period, which is the time between infection and symptom onset to try to, these are very basic parameters for epidemiology that were needed to make accurate assessments. So this data was then quickly used and adopted by the community, and it was only possible again through this open data sharing policy that we had around the data that we brought together. I want to too much detail here, but like now we have a system in place where this data ingestion actually happens automatically through computational methods and also some machine learning tools to understand, you know, where are these cases popping up and how do we build this into the database. And there's obviously a cleaning process, as you can imagine. This data is very, very complex, coming from multiple different sources and now about 142 countries in the world. And when you look at this this type of information online, and we're about to launch this website over the next couple of weeks, and I'll after this seminar webinar send a few of those links through. You can not just investigate kind of where cases occur, but much more importantly, you can evaluate the data quality. So you can think about, you know, where is data reported in an accurate and sophisticated way, and in which countries or in which geographies is that not the case so much. So we've all heard about sort of, you know, the potential issues with data across the United States, for example, where there isn't a centralized location where data is actually being assembled and coming together. And sort of that it becomes incredibly visible in this process. So states in the United States, for example, report data very differently. Florida reports individual level case data and at a very high granular resolution. Other states only report aggregated case counts at a weekly level, you know, and those things do matter, and they matter not just for us as a public to be informed where transmission occurs, but it's obviously incredibly important when we try to make assessments about potential reopening strategies, but also assessing kind of like basic parameters like the reproduction number in each of those localities. And this will enable sort of that communication, and hopefully will then enable trust in data and trust ultimately in the government to make good decisions. But then the question really was, okay, well, how do we use this type of information together with other data sources to understand the effect of certain measures in reducing transmission across the world, and how can that help us understand ultimately what type of measures are relevant and important as we are sort of moving through this pandemic, and also as we are moving obviously in a state where lots of countries are reopening their economies and reopening and allowing travel again. So I always like to show this kind of slide on the top right here. What you see is the travel times from London across the world in 1881. So the colors indicate sort of the time it would take from London to travel to other places. And what you can immediately see, you know, like in 10 days, you can travel across Europe and into some of Russia really, but it would take you up to 30 days to go all the way to China, for example. So you can imagine that infectious diseases would travel much more slowly. This, of course, has changed dramatically over the period of industrialization, and especially sort of the increase in flight travel pre-pandemic, of course. And what you can see here on the bottom is just a screenshot, and this was like from the New York Times, I think in February, published how many planes are actually in the air in China on a regular day, and this was pre-lockdown on January 23rd. And this is about 12,000 planes are at any given point in the air. After lockdown occurred in China, this obviously reduced to a lot fewer flights and about 1,600 flights. So you see sort of behavioral adjustments imposed either by government restrictions, but also people don't want to travel anymore because there's a perceived risk, of course. But that's very, very different to what we would have seen in like 1881. And that also enables this rapid spread of infectious diseases. So what we were trying to do then is trying to evaluate the effect of travel restrictions from the epicenter from Wuhan in bringing the epidemic under control within China. So this was a paper, I think it was published the day the UK went into lockdown on March 23rd. So really early on, trying to investigate this, combining information about the epidemics themselves with case numbers, together with information about the traveling network in China using Baidu data. So Baidu is the largest search engine in China, so similar to Google in the United States, for example. And then the records of travel between different places to try to anticipate the sort of spread of the infection throughout the country. And what we also could include is information about the travel histories of individuals that had reported travel history to Wuhan. So what you see here on the map on the right-hand side is colored by the day pre-quarantine, the sort of traveling network of individuals that came out of Wuhan. And you can see kind of the distribution is relatively wide. So most of their travel, you know, to the big provinces with large amounts of people in eastern urban China, but also really to the other provinces which are further away. So really expanding across like this entire network of cities across the country. And you know, like China has urbanized dramatically over the last 30 years, really. And it's only expected there's an incredible amount of travel going between places with high-speed rail connections across the entire country. And Wuhan serves really as that center and hub for travel within China. And what we were trying to do then is trying to say, well, if we have information about cases in Wuhan, we have the movements from Wuhan to other provinces across China, how predictive is that of the transmission that occurs elsewhere? So what you would be expecting in a classical sort of model would be like, if you have more connections with more people who are infectious and traveling, there would be more arrivals of infectious individuals that would trigger local outbreaks, either in their families or communities and so forth. So unsurprisingly, for example, an analogy to that would be the early importation of the virus into New York City and the large outbreak there, which is of course related to a huge amount of importations that occurred into New York City that then triggered local small outbreaks in communities where people then travel to. Which could be either families, it could be like neighborhoods, it could be super spreading events that occur at large gatherings and so forth. In China, it was incredibly predictive. So travel and cases in Wuhan into other places was incredibly predictive of spread elsewhere, which, you know, we were quite surprised about how predictive it really was. So it's like it's almost like textbook epidemiology if you think about really where these cases then were found. But what China was very good at is tracing individuals that had come infectious into another province. So what you see here on the bottom is the epidemic curve in Guangdong province. I don't know how many of you, maybe some of you have been to the Pearl River Delta. So this is a massively urbanized area with lots of people living together, very close to Hong Kong. Which, you know, is an incredibly large area of urban center. And they received a lot of imported infections, especially from Wuhan. So you see that in the blue here. And what you see on the bottom is the green, which are the local infections. And what you can see here, you know, normally an epidemic curve looks like goes up and goes down. But what this looks like is the cases that come imported go up and down. But that's because of the shutdown and the lockdown of Wuhan. But the local infections never really took off. And it was really striking for us to see, because this speaks to the sort of successive, ultimately not allowing infections when they have come into the country to then grow very, very large. And this is where lots of other countries, I think, around the world have failed, is preventing that local dynamic to really take off. And it's encouraging that it's possible, right? So similar things we have seen in South Korea, very similar things we have seen across New Zealand, some parts in the early epidemic in Australia, but we have really not been able to do that in Europe and the United States, and also not in Latin America mostly. But we can kind of quantify that effect of the travel restrictions through this process, and also identify, almost like encouragingly, that there is a possibility to stop this spread. What was also possible to observe from this detailed epidemiological data was that, and maybe this is an anecdote that's also true in many other places around the world, especially it was true in parts of Mexico when I looked at that data, is that the initial infections that were reported were in male at a sort of middle age between 35 and 45. So most of the initial infections that are mostly travel related were in sort of like age groups of businessmen traveling. Once, however, the disease transitioned into local transmission dynamics, the ratio between male and female equaled out to 1:1, and also the age of the infection was actually more relevant, like more similar ultimately to the underlying population. So this would indicate that transmission then was spreading into the communities where family members would become infected and so forth. And I'm going to talk about this a bit later, but just to already say this, in Mexico, for example, the initial big clusters occurred from people returning from travel from skiing in Vail, I think, in North America, and then sort of, bringing in the infections into a certain community from where it then spreads locally into other communities. So that's kind of the process of this spread behavior. And with such detailed information, we can actually uncover some of these patterns, which could inform in the future, especially, which populations should be targeted when it comes to testing strategies, for example. What we were then very, very interested in locally was trying to understand how population crowding especially was affecting the spread of COVID-19. And many of you may notice, some of you who have read reports from New York City, is that the different boroughs have different population level attack rates. So population level attack rates basically are like what fraction of the population was infected by the virus at the sort of end of the first wave of the epidemic. And you can imagine, and this is well known for influenza, that when a pathogen arrives, if it arrives into a place where people are living closer together, there's more possibility for onward infection, which then ultimately triggers that there are more people infected, which then in turn means that there are like a higher proportion of people infected. So some boroughs in New York City that are relatively, more poor, for example, and people live more crowded together and have larger household sizes, have vastly different population attack rates than locations where there's there are less people per square meter and so forth. And we see the same pattern in Spain. We see the same pattern in London. So for example, in the UK, London has, preliminary results show a population level attack rate from 13 to 17%, whereas rural areas across the UK only 3 to 4%. So there's a vast difference really between those population level attack rates. So we built a mathematical model to understand this more formally with regards to crowding. So what we found is that population crowding is a very good predictor of population level attack rates across the world. And we exemplify this for the Chinese epidemics in the Chinese cities and for epidemics in Italy. But there are certainly also indications for that to be true across other parts of the world. And why is this so important? So why do we need to know this? We need to know this for the concept of understanding how many people have been infected, so that when we start vaccinating individuals, how many people in addition to that need to be vaccinated, so that we can protect the entire population against a new wave of an outbreak as the vaccine becomes available. I'm just going to skip over this, but like once this model was built, we could also predict how these epidemics look like across the world, and like how we expect these population level attack rates to differ depending on where you are in the world. I know that there are some of you from Mexico, so I want to also jump in to talk a little bit about our work in Mexico. So we work in part with the Mexican government, but also many colleagues at the different universities across the country to understand the epidemic in Mexico, which is a very interesting epidemic in many ways. So what you see on the top left here is just a map of like how many cases have been reported across different municipalities across the country. And what you see on the bottom left here is the different epidemic curves for the different states. So what you can see here very clearly is that Mexico City and Mexico State initially received many importations that then triggered large outbreaks there. And it took quite a while until those infections then were imported into other states where the epidemics took off much, much later in time. And this may be a bit too subtle and a bit too detailed, but what you can also see in figure panel D here is that the initial groups of people who have been infected, mostly as a share of the total number of people who have been infected by by COVID-19, or at least were confirmed with that disease, were in age groups between 30 and 69-year-old males. So that's the orange and red curve here. And this is, between the time of really early March, when the first infections were recorded, all the way down to sort of the period in late July, where we are today, where it's sort of more equal between male and female. So there's certainly sort of some demographic aspects that play into this dynamic of disease spread, which we can observe. And it's not just true for China, was not just true for the UK, but certainly also true for parts of the early phase of the epidemic in Mexico. And the second thing that is, of course, an important aspect when we think about vaccination is like how people are connected to each other. So we're looking at sort of human mobility data here, and we see two screenshots, or like two snapshots of the movement network in Mexico. One is before travel restrictions were put in place, and one is after. And the most striking thing that you may not be able to see in so much detail here is that Mexico City became increasingly important in the mobility network across the country. So whereas initially in a normal situation, a normal sort of day in Mexico, travel happens across multiple different states and between municipalities, the central importance of Mexico City is actually increased as a result of travel restrictions that were put in place. So and why is this important? This is important as we're thinking about vaccination. So if Mexico City is still sort of the hub where people travel, even though there may be some restrictions in place, it becomes the place also where the biggest gains may be made when it comes to vaccination campaigns. Because once the epidemic is under control in sort of the biggest hub, which appears to be Mexico City, it may also provide an opportunity that if that epidemic is brought under control, that also then propagates through to the other locations across the country. And these are the sort of subtle findings of some of this research that are, however, critically important as we're sort of moving to a stage of vaccination implementation and moving forward in that. But I don't want to bore you too much longer and just give it a little outlook. So what we found over this period of this pandemic is that open, detailed epidemiological data are incredibly important for innovation in epidemiological models, which ultimately enable us to illustrate which interventions may work best in controlling an epidemic. We found that human movements and human mobility was one of the factors that were even more important for this pandemic than we would have thought for a normal pandemic it would be the case. Some of you may remember these reports, but for example, the UK received a lot of travelers coming into the country between April and late March, which actually triggered lots of local infections across the United Kingdom, which could have been prevented if potentially these people would have been traced better, or there would have been the quarantines implemented on people returning from travel. We also found that crowding and early invasion of the pathogen are factors that shape the numbers of people who have ultimately then been infected. And that's mainly because we learn through an epidemic, right? The locations that have received lots of infections early were usually the ones where people didn't really know about the disease, and like the disease could spread very freely. Whereas later on, once that was the realization was there, people were much more protective and had understood that that there are certain measures that can be put in place to bring the epidemic under control. But then going forward, I think we really need to be in a place where we bring those aspects together as we're sort of moving into a phase where potentially vaccines are on the horizon. And I'm very happy to receive any questions and be happy to answer those.
Thank you, Moritz. This was fascinating. We've actually received a few questions here in the Q&A, and if anyone has more questions, you're welcome to post them either on the chat or the Q&A. We'll be monitoring both, and we'll relay both of those channels back to Moritz. And I see we have a couple of questions here that have to do with understanding the COVID-19 under the lenses of the 1918 pandemic. So one of the questions that we have here is, what lessons can we learn from the 1918 pandemic? When could we expect for things to get back to normal?
I mean,
Easy
the
questions,
second
only easy
question
questions for
there,
you.
it's quite a tough one. And I don't know where that question came from in terms of its geography, because that surely depends. I'll start with that question first. Until we are back to normal, I think will take quite a while, and sort of at a global scale, speaking at a global scale. However, for example, over the last few weeks and since mid-July, things have been relatively normal, or definitely more normal than a few months ago here in Oxford. So there was definitely a period where, pubs started reopening, people gathered together again a bit more, all with the precaution of wearing masks often and so forth. But there's certainly like a way in which like life could resume in many ways that was definitely much more normal than before. And unfortunately, all probably in the Americas, in Europe, people have been traveling. People have gone back to their summer holidays. So there's a certain bit of normality that kicked in really. Now, of course, there's this critical period moving into the fall over here in Europe, where infections are rising again. So we will see how that works. But we have learned so much over the last 8 months, right? And we sometimes have to remind ourselves that it's only been 8 months really, that relate to like, what kind of measures actually work and what kind of measures don't work. And I think people are incredibly behaviorally adjusting to those types of information that we have learned over this period. With regards to the 1918 epidemic or pandemic at the time, of course, I think there were lots of analogies, especially in the beginning, that people made. So this was the last pandemic, 100 years ago, 102 years ago, and how can we use that to inform what this could look like, right? And I think the biggest sort of learning from that was that it's certainly totally possible, as you've moved through a first initial wave of the epidemic, that there is a second one that can pop up, right? And I think we've seen lots of that, the resurgences already in parts of the United States and in Mexico after the reopening. I think it was late June or early July. There was certainly like certain increases of cases happening. And then we see the same thing happening over here in Europe. And I think that the most important aspect there to remember is that there are just so many people still susceptible to infection. So, and that's what we knew for the 1918 pandemic as well. Those second waves come along because people are still susceptible, and there's still enough susceptibles left so that it can further spread throughout different places.
Understood. Well, there's a couple more questions about how COVID compares to other pandemics. The first one is, how does the mortality rate of COVID compare with other pandemics, such as the 1918?
Pandemic. Okay. Yeah, good question. And I think one that was, hotly debated throughout this epidemic, especially in the beginning, given that there were quite a few people out there who thought this was just another flu, right? We remember this from the early discussions. I think we're settling somewhere at 1% mortality rate in the context of this pandemic and this is not the case fatality rate, this is the infection fatality rate. So for those that we actually know anything about them being infected. However, I think we've also learned quite a lot through the evolution of that fatality rate through time. So initially in the epidemic, not much was known also about therapeutics. Not much known was about how to treat patients in general. Initially, there are lots of people who were put on ventilators, for example, which actually turned out to be often quite a bit too early for people, and there was actually an increased risk of that for longer-term impacts of those treatments on the individual's health. So we shouldn't be thinking about those as static measures. We should be thinking about those as also those that we can do a lot about today. We could do much more today than we could do in January and February. And then we are certainly thinking about sort of if people become potentially infected a second time with this infection. People have been documenting that in Hong Kong right now. Does that really mean that they're severe infections, or does that actually mean that there are potentially mild infections? For example, the patient that was reported in Hong Kong didn't actually have any real symptoms, but was picked up at the border coming back from Spain to have had, a different COVID strain than the one that was previously identified in that individual.
Yeah, absolutely. I suppose it's an interesting question as well. When does a pandemic really start, and how can you say it's over, right? But well, following up on that, there was a question on, is this pandemic truly a rare event, or is there any reason to suspect we have another pandemic coming up sooner than 100 years from now?
I mean, very hard to predict, right? We definitely failed, so definitely have to question kind of the methods and methodologies of epidemiologists around the world, really, in how well we are able to anticipate those epidemics to occur. The general consensus is it's extremely hard for those rare events for them to actually be predicted. And some of you may work in finance or other areas of research where that very rare events are extremely hard to predict, especially the timing of those events. We just know that they would potentially occur. I think, and this has been something that around the community is actually quite well accepted, is that we do know that those events will occur. It is more about the surveillance systems to be in place to pick them up early and react early. And I think this is, a stark reminder of that, right? Some diseases like SARS in 2003 could have become a global pandemic. We got lucky and it didn't. And that was probably because of some features in the biology of the disease. However, that was lucky, right? So that could have happened in 2003. So this was only 17 years ago, really. So these things can happen much more often. We are more connected today than we were ever before. If we go back to air travel, air connectivity like we do now, then that's a huge risk. If deforestation and other factors and processes will continue at the pace that they are today, then that will potentially have a huge effect on more importation, like more introductions of novel infections into the human population that could trigger large outbreaks.
Understood. Thank you, Moritz. You've actually touched on a few topics that are subjects of questions as well. One of them is, can you talk about herd immunity and whether this could happen without a vaccine?
Yeah, I mean, it's a very good question. I think comes up every once in a while, again and again. I think we are all hoping for a stage in which we can go back to sort of a normal state. I think there are a few questions to that. One is, what is the actual appropriate level of herd immunity? That very much depends, as I also mentioned in the slides, on how we are connected. So you can think about it in this way, like if you have a country that's extremely well connected, that ratio or like rate needs to actually be quite high. So, somewhere around maybe 50-60%. If you are less connected and people are actually not interacting so much, then that ratio actually drops quite a bit. So there's some variability in that. And that really depends on the assumptions that you're making in those types of models. Now, some places have reported extremely high rates of population level attack rates. Some favelas in Brazil, some areas in India have reported huge amounts of infections being detected in individuals through antibody tests. I think the jury is still out on like those publications, still need to know and definitely check on sort of the quality of some of this work. However, that would indicate that there are some places who have had a huge amount of people already infected where the risk of resurgence may be smaller. The strategy for herd immunity in, for example, the UK is not one that's feasible. As I mentioned, about 13 to 17% of people have been infected in London, 3 to 4% in some other counties around the country. That is certainly not the amount of population that needs to be infected to reach herd immunity. And going for that strategy will be very deadly. So lots of people will die if we go for that.
Well, and following up on that, we've got a couple of questions on borders. Maybe I'll state both of them, and then I think you can find a way to respond to both in the same breath. But it looks like closing borders in pandemics is a key policy to contain the spread. Does this sustain in the medium to long term, or closed countries will face a resurgence in cases due to a lack of herd immunity? And then the second question is, again, thinking about borders. Apparently there was a study from Colombia that stated that if the United States had a lockdown sooner, many deaths in the US would have been avoided. Do you agree with that study? Could you comment on it?
Yeah, I know the author of that study, I think, but let me go to the first question. Let me go to the first question first. Travel restrictions are useful in containing the spread. I think that's a non-controversial statement. I think that's scientifically been shown. Now, and that is very plausible, right? If you have some place that has an infection, another place doesn't, and if you prevent people to be infected to go from A to B, then there wouldn't be an importation of a disease. Now, politically, that's of course a whole other discussion to have, and I think there's ethical implications to that too. I would just give a few examples. For example, South Korea was able to contain the epidemic by doing active contact tracing and lots of testing of the population. So this is a strategy where people could still come to South Korea. There were just like certain restrictions on, like following up on these individuals, like having daily phone calls to make sure that they are not symptomatic and so forth. That had the ability with those resources to contain the epidemic in South Korea, for example. New Zealand went for a different strategy. New Zealand just closed the border immediately when they heard about this occurring, and they never actually really had infections in the country that were locally transmitted. So that was an effective strategy at the time. Now, as we're sort of moving out of the pandemic, hopefully at some point, then of course New Zealand will be highly susceptible to novel importations and then local spread, because there isn't anyone who has actually been protected. But if there was a vaccine, of course, that could balance that out. And we've seen this in Australia, for example, initially contained. Now we had a big outbreak in Melbourne that occurred. I think what the European strategy is mostly is trying to build bridges. So identifying locations where there are low numbers of cases, and then allowing travel between those places that have low numbers of cases, and balance it out against it. And if there are like rising numbers of cases, then there will be like certain measures put in place based on that very reactively. Europe can kind of do that because there's a European coordination system in place. I think the US does not have a strategy like this, for example, between the states, and I'm not sure about Canada or Mexico in that space. Now, on the second question around like shutting down early to prevent lots of numbers of infections, that could have prevented lots of deaths. So I think this is, I don't know if this refers to a study that was summarized in the New York Times, but there's certainly discussion about that. What we know from our work is if there was an early shutdown, or let's say there was early restrictions put in place, whatever those restrictions may be, then that had a huge effect on bringing the epidemic under control. So for example, in Germany, Germany shut down very early when there were like lots of like very few cases in the country. That has prevented the epidemic to grow very, very large, which had a huge effect on the ultimate size of the epidemic. In contrast to that, the UK took a long time until a full lockdown was implemented, with lots of deaths already reported in the country, which meant that the disease had already spread to many places and wasn't as controllable anymore as, for example, the epidemic in Germany was. So I think it's uncontroversial to say that early measures help contain an epidemic more, because there's just fewer contacts you need to trace, and ultimately that's then easier to that the epidemic then becomes controllable. How exactly in terms of the quantification of it, I think the jury is still out on that, like where we actually can measure the counterfactuals in a sophisticated way.
Thank you, Moritz. We have a question here from Dr. Rahul, who actually used to teach at Oxford. And it's a question around something that you mentioned in your talk, which is on data quality. He's asking whether there's open access to your database so that we're sure it's more reliable.
Yeah, absolutely. So data has always been open, is continuously open. So I can certainly send through that link to, you can email me, and then I can share that information with the colleague from Oxford. And yeah, so it'd be nice. We'll be happy to do that.
Perfect. We'll gather all these questions as well and make sure those are sent back to you. But we've got a couple of questions here that have to do with gender as well. And the first one is, does your data support an article in, well, today's New York Times that coronavirus hits men harder as women produce a more powerful immune system than men do? And then the second question is, why do you think initial infections were predominantly in middle-aged males?
Yeah, two very good questions. On the first one, I can't comment too much. I'm not an immunologist, unfortunately. But I haven't seen that study myself, so I won't be able to speak to it. On the second one, however, so we have documented this for China and other places around the world, as well as showed you the data for Mexico as well. So we anticipate lots of that as business travel. So men are more likely, in some countries at least, to do within country business travel. Even between country business travel is more likely in that. In that age group between 30 and 55-year-old males. So that's one, ultimately that's one explanation as to why to see more infections in that population age group. Secondly, it could also be related to healthcare seeking. So men have more severe infections potentially than seek care with doctors, which that would potentially explain some of that difference. However, we don't really anticipate that to be such a big case because we see it equaling out as we move through the epidemic. So I would bet on the first hypothesis in that case, and we only see that really in the beginning of pandemics too, when they occur.
Great, thank you, Moritz. We've got a huge number of questions, but let me focus on two of them right now, which have to do with travel. The first one is a little bit more open-ended, which is, what are your thoughts on the future of travel, particularly air travel? And the second one, which I think is very related, is, does the data provide any guidance with respect to the transmissions that are caused by the act of traveling itself, for instance, in airplanes or trains, versus transmissions caused by people who have arrived at their destinations already?
Right, yeah, two very good questions. The future of travel, I think I think there are a few scenarios really. There was a debate about sort of immunity passports. So people saying, well, I've been infected, so I should be traveling, or should be allowed to be traveling, for example. So there was one. I think where we will be moving to, which is more likely, is as the vaccines become available, hopefully, that there will be something similar to common other vaccines, like the yellow fever vaccine, for example, where people would need to show that they have been vaccinated at the point of entry, for example, or before going on a plane. So those are kinds of scenarios that are being pointed out. Then there is, of course, and I don't know where that question exactly came from, but what other countries are trying to do is enhance testing of individuals that do travel. So either at return or before they travel. So the idea in Germany, for example, is free testing at the airport. So people come back, arrive, get tested, and that way it prevents sort of that community spread, at least for a little bit, or even though they can obviously get infected a bit after the arrival time. But those are the types of strategies that are being sort of now explored. I think as we are moving forward, there will be lots of uncertainty about it and lots of heterogeneity. So New Zealand may do it very differently compared to a country that had lots of infections. And then there will be maybe barriers, like people going between different countries where there's lots of economic activity, and that's more encouraged than between other places. So I think those are scenarios that we will we'll learn about as we sort of move through this. What we do know is that there are certain ways that we can prevent lots of like importations and then new chains of transmission to occur. On the second question around like where is transmission occurring, yeah, our data certainly provides insights into that. So maybe one anecdote of that from the initial data that we looked at for China was that about a third of the individuals who later became positive were traveling already when they had mild symptoms. And this gives some indication of like that transmission event had already occurred before. People then traveled and then became later positive. From the evidence that we see today, we do not think that the transmission rates on airplanes and trains is incredibly high, which is related, and we believe much more that super spreading events occur in like crowded areas with little ventilation, and that they would occur in very close contact. There are not very many reports of people who have been infected in transport, at least not that we have seen over the last few months, but that may change.
Well, and talking about travels, there's a question here on what is it about ski holidays that make them such potent incubators for this disease?
Yeah, I think, a couple of things there, like similar to meat plants. It's cold, people's immune systems may be a bit affected there. People spend a lot of time in crowded indoor spaces, especially after the day out in skiing or doing other activities in the mountains, which could trigger, those infection events, really. We've seen this for Ischgl and other places in the Alps where lots of people have been infected at parties and where they congregated in small spaces with lots of people together. So those would be some of the hypotheses that I would have.
Right, absolutely. Well, many folks have thanked you for the excellent data and the maps from China and Mexico, and are wondering if there are any data sets or maps that show the spread of COVID-19 in the US over time.
I think there's a good New York Times piece that I can certainly dig out, which shows kind of the spread simulated mostly because we don't really know how it really occurred from the big hubs. So a lot of that is related to the early importations into Washington State and then New York City, and then the spread onwards from those places. So there's certainly a lot of evidence for that continental spread within the United States to the big hubs. We all know this, like we see the different waves occurring for influenza every year. It's first the East Coast affected, then the West Coast later on. And that is because, there's so much air travel between these places and the weather is obviously a bit different. I will dig that out. I can send that through, but there's certainly some information out in there in the web.
Perfect. Thank you, Moritz. I actually want to be conscious of your time because you're doing incredibly relevant work for all of us. So maybe I'll do the following. I'll gather the questions that we couldn't answer. I'll share those with you, and and each of us in our chapters can share those answers to our respective mailing lists.
Yeah, absolutely. Happy to provide some more detailed answers. Just send them through via email, and I can.
Perfect. Thank you so much for that. Well, our time is up. Thank you so much for your time, for generously answering all of these questions. This was such an engaging conversation. I'm glad we're wrapping up the week of this. Sean, David, thank you for joining as well. If you have any final words, you're welcome.
Karine and Moritz, thank you very much.
Thank you, and thanks for having me.
Thank you, Moritz. Appreciate it.
Thanks, bye.
Bye. Take care.